Hello, everyone. I'm Dr. Carmen Puliafito, and today I have with me Dr. Gemmy Cheung, who is head of the Medical Retina Division at the Singapore National Eye Center. Gemmy is a foremost expert on polypoidal choroidal vasculopathy. Welcome to Retina Synthesis.
Thank you very much, Carmen.
Can you, for those listeners that are not familiar with PCV, can you define polypoidal choroidal vasculopathy?
Sure, thank you very much. Yeah, indeed, I think our understanding of PCV is still evolving. We don't fully understand this quite enigmatic lesion. As we all know, historically, it is something that is best identified on indocyanine green angiography as aneurysmal outpouching or dilatations at the terminus of a branching vascular network. More recently, with OCT analysis, we have better depth resolved understanding, and we can see that majority of these lesions reside between the Brooks membrane and the RPE, and therefore placing it at the same plane as a type 1 neovascularization. So, and in addition, with OCT angiography, our appreciation of the branching vascular network, or now we call it branching neovascular network, it is much better visualized than in ICGA. So based on all these imaging discussion, now I think many of us consider PCV at least a variant of a neovascularization or neovascular AMD. Of course, there are still differences. We've talked about similarities, differences in terms of, first of all, is population. We know that it's much more common in Asian populations. We just talked about in my clinic, we're talking about up to 50%, half of the exudative AMDs belong to this PCV subtype. In European white populations, it's been considered perhaps slightly underdiagnosed because ICGA is not always done, but still up to estimated about 20% of the clinical population with exudative AMD. Another important difference is the differences in the drusen background and also the choroidal thickness. In PCV, we do tend to see some patients with no drusen, or the drusen subtype tend to be more of what we call the pachy-drusen subtype. It almost never coexists with reticular pseudodrusen, and the choroidal thickness tend to be not thin. Now, it's very hard to put a threshold to say what is considered thick, but generally, they are at least 200 and beyond, not the kind of like, almost like the reverse phenotype of a type 3 BRAC kind of lesion with thin choroid and pseudodrusen. So that's a very quick summary of PCV. So therefore, it is quite, it naturally follows that when we talk about therapy, we always wonder, do they respond differently or not?
Can you talk a little bit about the evolution of therapeutic approaches for PCV?
Sure. Yes, going back maybe 15 years and beyond, in those days, these are talking about ICGA based, when OCT was not even around. It was quite, in a way, primitive. It used to be based on focal laser to occlude the polypoidal lesion, because that's the most obvious lesion we can see based on ICGA. Subsequently, with PDT, it has been shown that with PDT, we can lead to polypoidal lesion closure on the ICGA. And in fact, they tend to better visual outcome have been reported with PDT in PCV compared to in typical neovascular AMD. Then subsequently, when anti-VEGF was introduced, that was quite an interesting period of transition. I remember, especially in Asia, partly related to the reimbursement system, at that time, the first agent widely used was actually bevacizumab, and the posology was very much PRN, and people go into treating PCV with PRN, bevacizumab, kind of with a try and see kind of mentality. And with those kind of experiences, it had not been good at all. It was reported that anti-VEGF at that time can temporarily reduce or control the exudation. But going back to the traditional outcome of ICGA closure, with bevacizumab, definitely we were not getting good results. So during the first transition, the vibes of anti-VEGF monotherapy was really not good for PCV, and there was proposal of whether PCV is something completely different, doesn't respond to anti-VEGF. Now, then subsequently, with ranibizumab coming along, there was quite a famous trial out of the Summit series. We have the Denali and Mont Blanc, which demonstrated that in typical neovascular AMD, there was really not significant additional benefit of adding PDT to ranibizumab. Whereas in PCV, that was something a bit different. So Everest 1 and followed by Everest 2 demonstrated that with combination of PDT with ranibizumab, it achieved superior visual acuity outcome, which was about 3 letters compared to ranibizumab monotherapy. But the main, so 3 letters, you may say, how significant is that? But the main significance was actually attributed to polypoidal lesion closure, which is an ICGA-based anatomical outcome. And there, the difference was one-fold difference. With combination with ranibizumab, it achieved closure of about 70%, whereas with monotherapy with ranibizumab, the closure rate was only about 30-something%. So with ranibizumab, still the feeling was that monotherapy works to a certain extent. Eyes were gaining 1 line, about 5 letters, which is not bad, but with ranibizumab, adding PDT may help. Now, the main change came with the introduction of aflibercept in a kind of pro-monotherapy trial design in the PLANET study. So in the PLANET study, the 2 arms that were compared were aflibercept 2 milligrams monotherapy versus aflibercept 2 milligrams with rescue PDT. So the design of the study was that the rescue criteria were actually quite hard to achieve. Patients have to have lost some vision with continued activity, such that at the end of the result, we found that only 17 to 18% of eyes ever met that rescue criteria. And as such, it was very much a majority of participants were treated with aflibercept 2 milligrams monotherapy. Now, in that trial, patients gained 10 letters, over 10 letters, 10.7 and 10.8 letters. And the small group that received rescue therapy did not demonstrate a significant difference. Now, there is a lot of limitations because the power is limited. But nonetheless, if we look at only the aflibercept 2 milligrams monotherapy arm, the outcome was that they gained 10.7 letters, and majority of them had a reduction in OCT. And that also reflects during this period of time, our anatomical outcome in clinic. We have moved away from dye-based angiography, and we have come to use OCT also as the main kind of assistant in terms of surrogate marker. So with good drying effect and good visual acuity outcome, that really shifted the balance of, and coming into clinic, the acceptance of many of our colleagues to shift over to monotherapy. Now, there may be some differences in terms of the agent, particularly. So the evidence so far seems to be stronger from aflibercept trials compared to ranibizumab trial. But nonetheless, in terms of the overall approach, that is the time when most of us have become much more accepted to monotherapy with anti-VEGF. And surely in clinic, nowadays we start off with monotherapy and many patients do well and will continue with a treat and extend protocol. There are still a small group of patients, probably 20% or so, who do not respond so well, in which case we may still consider adding PDT as an adjunct later on.
What about, before we move on to faricimab, what about 8 milligram aflibercept?
Yeah.
Does that have any added benefit?
Sure. So 8 milligrams, I mean, that's a great question because it's a natural progression from the 2 milligram evidence. So we can look at the PULSAR study in which there was a subgroup, it's a pre-specified subgroup analysis of the PCV cohort. Here, the PCV cases of the participants were identified through ICGA, which the PI submit. So it was not a mandatory test. There is probably some sort of selection bias, either by practice, by country of the site, or by the characteristics of the eyes, which led to that eye having had an ICGA. But it was centrally graded by the Central Grading Reading Center, and out of which 139 eyes had PCV confirmed based on ICGA. So first of all, that is adds to our confidence that about the precision of the diagnosis. And based on this subgroup, in terms of the BCVA gain, they were similar to the overall non-PCV population. And in terms of comparison between the 2 milligram Q8 versus the 8 milligram with the prolonged dosing, again, the 8 milligrams was not inferior to the 2 milligram. So similar efficacy to non-PCV population. And finally, in terms of the durability, also similar with the proportion of eyes that could be retreated at Q12 or Q16 or longer retreatment interval. Now, let me just try to remember. Yeah. I think I'll stop there about the PULSAR trial. So basically, the key message is with 8 milligrams is that because the trial is designed to understand durability. So what it showed is that within the PCV subgroup, we can also achieve longer durability with reduced retreatment interval, but achieving the same outcome. There was not the opportunity to understand whether 8 milligrams would do better than 2 milligrams because the treatment protocol was such that the 8 milligrams could not be retreated at a more frequent interval.
Yes, it was a non-inferiority trial against
Yeah.
2 milligrams. So the treatment interval was dictated by that.
Yeah, absolutely. Yeah, sometimes we ask, well, if 8 milligrams was allowed to be used at Q8, would we achieve superior outcome? Well, we would not, maybe real world studies would be able to answer that better.
So at Angiogenesis 2026, you presented the results of Faricimab, a very important study looking at Faricimab for the treatment of PCV. Can you tell us a little bit about the study design?
Yeah, absolutely. So, I mean, it's a really exciting time. It's good to see so many agents being evaluated specifically for PCV. So, Selwyn, as you mentioned, evaluated Faricimab 6 milligrams in PCV. So, this comes on the back of course, the famous Tenai and Lucerne studies, which evaluated Faricimab in the treatment of neovascular AMD globally. So in that big study cohort, we try to look for PCV cases, and probably because of the inclusion criteria, such as the size of the hemorrhage, subfoveal hemorrhage, etc. So we found that there were very few cases of PCV that we could understand about Faricimab treatment. So we were not able to do a subgroup analysis. But something good out of it is that a specific trial, which is called Selwyn study, was designed to evaluate, is a phase 3B, phase 4, is single-armed, multi-center study studying Faricimab in PCV. And the study design is similar to the Tenai and Lucerne. So we started off with the loading phase, 4 initial injections at weeks 0, 4, 8, and 12. And then we do the disease activity assessment at weeks 20, 24, 28. And if patients do not show a disease activity or they do not meet the disease activity criteria, then they will continue retreatment during the first year on Q16. And those that show disease activity at week 24 drop down to Q6, Q12, and those who show activity early on drop down to the shortest interval allowable, which is Q8, and they are locked in at that interval until primary endpoint assessment, which is the mean of BCVA change from baseline at weeks 40, 44, and 48. So that first year design is almost identical to Tenayanusam. In the second year, there is more flexibility, and then retreatment interval can be titrated at each visit, and each interval can be either shortened, maintained, or extended, and the interval can range from a few can be as short as 4 weeks, and the most important is it can extend to explore Q20 weeks as well. So at angiogenesis, I had the opportunity to present for now the 1 year data up to week 48, and we'll talk about that in a moment. And right now, we're actually working on the 2 year week 108 data, and we hope to be able to release that later on during this year.
So tell us about the results.
Sure. So in total, we have 135 patients. They are recruited across about 38 sites across Asia. They are PCV confirmed by ICGA, by the reading center. The mean age was about 68 years, which is quite characteristics of the PCV population. They tend to be younger than the neovascular AMD typical age group. The CST at baseline was over 400, I believe about 417 micron, so indicating quite a lot of significant disease activity. So the starting BCVA actually was quite high, is 64 letters. If we think back, how does that compare to earlier PCV trials in Everest 2 and Planet, which I mentioned earlier on, the starting BCVA in those days was 58 to 61 letters. Here we start off with 64 letters. So if I jump to the primary endpoint in terms of BCVA gain, after the first 4 loading at Q16, we already saw a 7.1 letters improvement. And then when we look at then the the week 48 result at the end of the first year, that had gone up further to over 8 letters of improvement, which means that the average patient started off with a mean of 64 letters, and after 1 year of treatment, the mean VA was about 72 letters. So in terms of BCVA, I think that is really remarkable. The average patient is now reaching driving vision. In terms of CST, again, we saw robust reduction during the first 4 injection, which is minus about 140 micron. And then that was maintained during the second phase when the retreatment was at a longer retreatment interval. At the end of the first year, the mean reduction in CST was about 120 something micron. There is a large proportion of patients who had a dry retina. This ranged between about 76 to 80 something percent between the week 16 and the week 48, and that was quite well maintained, again, with the reduced retreatment. And finally, with PCV, always still want to look at polypoidal lesion closure based on ICGA. It kind of gives us a complete picture. And here is also a very impressive result. We saw that after the loading dose, 51% of eyes based on ICGA, based on reading center grading, had complete polypoidal lesion regression. And what is quite interesting is that between week 16 and week 48, we saw a further increase in the proportion. So at week 48, it went up to 61% of polypoidal lesion closure. So that really does make us come back to think, we know that the theory is that Faricimab does not only block VEGF, but here is not just another anti-VEGF you're trying. It has activity against the Tie2 receptor. So leading us to think there may be additional benefits, particularly in terms of vascular stability and in the polypoidal lesion, perhaps parasite disruption. The health of the parasite is important, and if we can restore that, we can help to remodel the aneurysmal abnormality. So what is interesting is that if we follow the first 4 monthly injection, we achieve 51% closure. But after week 16, participants are being treated less frequently. And I still find it very interesting that somehow during this less frequent, less intensive treatment period, we saw a further increase of 10% of polypoidal lesion closure, which does make us at least think it may be consistent with some vascular stability benefit. And finally, in terms of safety, there was really no new safety signals, no particular in PCV. We worry about retinal hemorrhage, we worry about RPE tear. There was no such signal. There was one case reported by the PI of suspected retinal vasculitis. This was independently read by reading center and was actually not confirmed. So overall, I think very consistent data from Selwyn, first in terms of function, very robust visual acuity gain of 8 letters with an average of 72 letters at 1 year. This is corroborated by robust CST reduction and maintained up to week 48, as well as ICGA closure and good safety signal. So that's a very quick summary in a nutshell.
It's really quite impressive. This was not a direct comparison with any other anti-VEGF agent, so we can't.
No, that's right.
We can't make definitive conclusions. But
absolutely, that's a great point.
But just in terms of your impression, is faricimab superior to aflibercept?
I think, yeah, as you said, this is a single arm study, so
Correct.
we cannot like make head-to-head comparison. So I would say both faricimab and aflibercept are achieving very good results in our clinic. For the average patient, perhaps both of them will work well. There are perhaps individual cases which are harder to treat, then maybe one can be stronger or can achieve better result than the other. But right now, as we mentioned, each drug has its own kind of uniqueness. With aflibercept, we've used it for many, many years. We have a longer track record of experience hands-on. With faricimab, it's still relatively new. So far, the impression has been very good. And what is most attractive is scientifically, it has additional anti-Ang2 function. I think the challenge is that even beyond PCV, even in neovascular AMD, we don't have a very specific anatomical biomarker that can tell us which part is specifically due to the Ang2 inhibition. We just still rely very much on fluid markers, which are non-specific. I think that is one of the challenges.
Now, PCV is a tremendously interesting variant subgroup of neovascular AMD, and its treatment has been controversial. But I think we're moving toward the world in which monotherapy is going to hold forth in the vast majority of cases.
Yes, I think that is also quite a fortunate situation with the difficulties in ICGA access, in PDT verteporfin access, and also the cost of those tests and equipment as well. So I agree, majority of patients as the first treatment to go to anti-VEGF monotherapy. There are a proportion of cases, however, that are harder to treat. Particularly, I think, is if the treatment interval is irregular, and we may experience that more in Asia. So some of the so-called anti-VEGF poor response may come from inadequate treatment. And the other, it is true that some eyes, another scenario is that once the eye has responded well, the treatment was paused instead of going to treat and extend. So in those eyes, perhaps in PCV, there is a higher chance of sudden recurrence in the form of a massive bleed. So that sometimes leaves a bad bitter memory in the treating physicians, and we get bitten by that experience. And then the third is there are still maybe a small proportion that we see the polypoidal lesion not changing despite monthly treatment. So in those cases, but they are the minority, do consider some additional occlusive therapy, you never know, some of these lesions are actually extrafoveal. So focal laser is still cheap and
Mm.
very amenable. And for those lesions, large lesions that cannot go away subfoveally, unfortunately, sometimes we still need to go back to access PDT.
Thank you so much for a wonderful discussion.
It's my great pleasure. Thank you.